This is an introductory video of active manual therapy. When you're doing fascial therapy, you never use lotion, and this is a demonstration of a patient that has decreased cervical rotation to the left, the asymmetry, so hypertonicity in the right trapezius and levator scap. The spiral line is indicated from the left to the right in the anatomy trains in this patient. And what we're going to do is correct some restricted motion in the upper thoracic and the C1, C2 complex of the patient. And here we go. So I'm going to start work on the spiral line. And what I'm going to do with the patient is I'm going to have them slowly turn their head to the left. And as they turn their head to the left, I'm going to be following the spiral line across the left and across the upper thoracic vertebrae to the right. This is going to induce motion in the fixated vertebrae in the upper thoracics. Now I'm going to continue that pass all the way down into the hypertonicity of the right trapezius when I rotate the patient's head to the left. Fairly simple, nice and slow. Now what I want to do is engage the patient's tissue. I want to make a connection with the tissue. I don't just want to start quickly. And then I guide the patient's active range of motion. This isn't passive. He's actively turning his head to the left as I work across the spiral line and across the upper thoracic vertebrae. And again, continuing that over to the hypertonicity of the right trapezius. And I want him to look down towards his left as I go across to the right. And I want you to take your arms off your legs and let them hang at your side. And keep looking down and reach down with this arm slightly as you look down. And we'll come back. So on the second pass, we changed what we were doing, corrected some impropriety on my part by having the patient's hands on his legs in the first place, and had him reach down with the right arm as he's looking to the left and now looking down also to the left. So we want to change and lengthen the process each time we make the pass. So on the third pass, and you don't need a lot of passes to do a big difference here, we're going to do the same thing again, and we're going to add the first two components of the second pass, which is looking across and him actually reaching down with his right hand slightly for the floor. And he's going to continue, and now he's going to be looking down. He's going to be looking down, and now what I want him to do is to have his eyes look all the way to the right while he's looking to the left with his head. I want his eyes to look all the way to the right as he's looking down. And come back. Now that cervical component that we changed and added to an ocular component and the cranial nerves, we're going to go up to the C1, C2 complex where 50% of cervical rotation occurs. Now, when you feel his cervical rotation on the transverse processes of C1, you can feel there's fixation in the rotation from this manual palpation. When he's going to the right, his C1 rotates all the way as he's moving. Now right here, his C1 stops to move. So I'm going to get on the anterior portion of the transverse process of C1, and I'm going to dig right into that with my thumb as he's rotating across. And maybe what we'll do is we'll turn the patient to the right on the swivel chair, and you can get an idea that I'm placing my hands on the transverse processes of C1. I'm getting right on the anterior portion of it and on the posterior portion on the right hand side. And I'm going to use that as a leverage and a fulcrum to increase his cervical rotation as he makes an active movement and I guide him from the forehead. And I'm going to bring it back. Now I'm going to do little stages of motion. And I'm going to hold it back as we rotate. And I'm going to hold it back as we rotate. And we're going to do that again. I'm going to induce motion on the transverse processes of C1. I'm going to hold it back from coming back to normal position when the head rotates back to center, and this way increase the motion of C1. Now, doesn't mean that this will correct the patient. It's quite possible, because this is second treatment, that he may need a chiropractic adjustment. What I try to do is induce joint mobility through grade 3 and grade 4 ranges of motion. So we've only done grade 3 at this point. We're going to do some grade 4 on the table, which I won't be able to show you on the video right now. And I'm going to have you look straight down, and I'm just going to hold the tissue while he looks straight down. Now I want you to start to look to the left. And I'm going to stay on the left side of the lamina groove as he rotates his head, and looks left as he flexes forward. And come back up. And let's try some of that with the right elbow, because really the olecranon process is your best friend. And we're going to go into forward flexion first. Now the patient has done this before, so his feet are level on the floor, and he's pushing slightly through his feet into his lower back. And I'll start to look to the left again. And we'll come nice and tall again. And we're going to work with the olecranon process down the right trapezius as he looks to the left. So I'm going to start here and engage the tissue. Now the patient's just going to, we're just going to keep your head nice and tall this time, and let the right shoulder sink to the ground. And I want you just to look to the left while I hang on to the right trapezius and right levator scap, and stretch that out while he looks to the left. Now, when we first assessed the patient, just before we turned on the camera, his rotation to the left, his right was normal, it was 90 degrees. To the left, he was actually only going about 30 degrees. So, we're going to go again. What we found was fixation in C1, C2, fixation in the thoracics at T3 and T4, and hypertonicity of the right side, total imbalance between the pecs and the upper shoulder girdle, and how that was relating into rotation in the spiral line from the left side to the right side, and restrictions in those areas. So we're going to gather the tissue on both sides and start to integrate the work now. And the patient is just going to look straight forward, and it's going to look down and curl up the spine while I engage the tissue quite heavily, and up to 40 pounds of pressure can be used. Now I can't do that because I just don't have that ability with the spinal cord injury and with the problems that I have with my spine from degeneration. But still trying to apply what I can in the patient and integrating the spine as we go forward and come back up. Then we're going to integrate again. We're going to have the patient slowly look down while we pull the tissue of the cervical region posteriorly and integrate it, because we of course want to realize in 99% of the population they have forward head carriage. Now there's a huge problem right here at his T1 that I'm coming across. So I want you to look to the left. Oh, no, stay exactly where you were. Oh, and go back to center first. And I want you to look to the left as you do that. So there's a grade 4. That's all I have to do is a little push. Just a little push. It's at the end range and just a little push. Not a fast thrust, nothing like a chiropractor, but at the end ranges. And then we'll slowly go to the left. And I'm going to follow it, and then when he gets to the end range of that, which is further now, I'm going to give a little push on that vertebrae and try to make it move a little bit to the right. I'm going to go right over the spinous process as I'm doing now and encourage that rotation that's fixated at that point.